Hello, I'm Kwan Dongwin, who is a uveitis and retina specialist from the Ocular Imaging Research and Reading Center at the Jerusalem Eye Institute. Today, I have a very great pleasure to discuss with you a couple of the management cases of patients with uveitis. And next to me is one of our stellar fellow, Dr. Aniruddha Agarwal, and both of us are looking forward to sharing with you how we have employed the technology of OCTA angiography in the management of our patient with uveitis. So Aniruddha, why don't you go ahead and share with our colleague here the cases that we will discuss.
Hello. So we can begin with the first case, who's a case of inflammatory choroidal neovascular membrane in a patient with idiopathic panuveitis. We have a 40-year-old male who presented to us with decreased vision and floaters in his right eye. This patient was evaluated for various etiologies of his uveitis, including toxoplasmosis, Bartonella, and Lyme disease, which were negative. The patient presented with peripapillary subretinal fluid and heme in the past, but was never treated with anti-VEGF therapy. Further evaluation revealed presence of hyperfluorescence on fluorescein angiography, which was peripapillary in location. In the late phase, the hyperfluorescence tended to increase, but we did not see presence of any obvious choroidal neovascular membranes. We have also seen presence of blocked fluorescence both in the early and in the late phase, which correspond to the heme that were observed clinically.
I think, Aniruddha, this is a good point to illustrate here. Certainly in a patient with uveitis, which we know may develop at any time during the inflammatory course choroidal neovascularization, and certainly we would suspect, we were thinking of perhaps this may be the case in here, and certainly we have done the fluorescein angiography as you nicely illustrated here. However, interestingly enough, in this particular case here, we see the hyperfluorescence and we also see some of the blocked hyperfluorescence because of the heme. But do you think that the finding on the fluorescein angiography alone seem to be quite demonstrative or confirmatory for a choroidal neovascularization?
Yes, Dr. Wen, as you described, we can see heme and corresponding blocked fluorescence, but we are not able to see any obvious confirmatory findings of choroidal neovascular membrane on the fluorescein angiography. And so we believe that this patient may require further evaluation to document such findings, because we know that heme in patients of uveitis may not be associated with choroidal neovascularization alone.
And that's important because the fact that unlike choroidal neovascularization that may be secondary to age-related macular degeneration, the management of patients with inflammatory choroidal neovascularization may have different options, and thus we would like to find out for certainty if indeed there's inflammatory CNV, in which case we may discuss with the patient various options to make sure that, for example, the inflammation, the uveitis is under well control so that the inflammatory choroidal neovascularization may also be controlled as well. So I guess we can proceed forward with looking some additional image, Aniruddha.
Moving forward, we performed the optical coherence tomography angiography using the OptoView Avanti system. And as we can see here, this is the image using the superficial segmentation slab of the retinal vessels which are appearing at the macula and the disc. As we can see in this image here, both the structural ENFAS as well as the structural ENFAS OCTA do not show any significant findings in the superficial retinal plexus. Moving forward, we see that in the deep retina, the outer retinal plexus also appears to be normal, both on the structural OCTA as well as the ENFAS OCTA. However, in the deep retina, the outer retinal plexus, while all the retinal vessels appear to be normal, in the temporal peripapillary region, there is a leash of vessels which appears to be very subtle in this view, but definitely seen in the region of the outer retina. As we move further below, in the region of the choriocapillaries, this leash of vessels becomes more prominent, and this is seen to extend from both the outer retina right through to the choriocapillaries layer.
I think this is quite important, Annie, that you described to the various steps. When one performs OCTA, one should also perhaps have in mind some potential finding that one may expect, and therefore the performer of the procedure should have in mind a clear history of what one is looking for. In this case, you have illustrated nicely, one need to go to the different layer and perhaps have to arrange the images so that we can expect to see what we have seen so far. So therefore, it's important to have a clear understanding of what we are looking for or what we may be looking for to help us to obtain the data that we need. And I think this case illustrates very nicely that with proper finding, with proper imaging technology, one can able to demonstrate the presence of a significant finding that may help to manage the patient.
Yes, and this device, the OptoView, allows us to perform manual segmentation, which was performed in this case to obtain segmentation slabs of appropriate thickness by adjusting the offset, so that we are able to very clearly demonstrate this leash of vessels which are extending from the inner choroid to the outer retina, as seen in this case here. And so this confirms our diagnosis of inflammatory choroidal neovascular membrane.
And as I mentioned earlier, in difference to, for example, the choroidal neovascularization that's secondary to age-related macular degeneration, where the treatment would have been often a first-line therapy, anti-VEGF agents that being used to control the CNV from AMD. Inflammatory CNV, on the other hand, have different options. Colleagues may argue that one needs to control the inflammation first, and this CNV may subsequently regress or at least improve in certain cases. So it is not always the usage of anti-VEGF therapy for this type of inflammatory CNV. In this particular case, for example, Annie, as you know, in this patient here, the patient elects not to receive anti-VEGF therapy at this time. Instead, he wished to be continued to upgraded his level of anti-inflammatory control, with the goal is that it will help to control inflammation better, and at the same time, as has been published, the anti-inflammatory treatment may also help to control the CNV as well. We also have explained to the patient, as you know, that in case of the choroidal neovascularization worsen, we always will have the opportunity to employ anti-VEGF therapy in conjunction with the anti-inflammatory treatment for him.
Absolutely. Moving on to the next case, we have a patient here of multifocal choroiditis who's a 45-year-old female who presented with vitritis in her right eye along with decreased vision. Her laboratory workup was negative for tuberculosis and toxoplasmosis. On examination, we find there is a large macular lesion along with retinochoroidal atrophy. There is no history of anti-VEGF therapy in the past. Evaluation using fluorescein angiography was performed, and as we can see here, there is presence of hyperfluorescence of the lesion along with staining of the peripheral choroiditis lesion in the nasal periphery. In the late phase, the lesion is still hyperfluorescent along with staining of the peripheral nasal choroidal lesions. We performed the optical coherence tomography angiography in this patient to document the findings at the macular lesion. And as we see here in the superficial segmentation slab, there are certain shadowing effects seen on the structural OCT as well as corresponding shadowing on the NFAS OCTA.
And perhaps you can also explain the red signal in the lower left image so that our colleague can understand why they're there and why it's important and what signal they may give to us.
Yes, so the two horizontal red lines, the red and the green, represent the segmentation slab, and the darker red areas below those lines indicate the flow through that particular region, through the blood vessels. Those are the flow signals. As we can see in this segmentation slab, there are no significant findings in the superficial retinal plexus. Moving further down, we find that there are changes on the structural OCT and corresponding changes on the NFAS OCTA, which are related to the retinochoroidal atrophy in the deeper retina, but there are no necessarily any abnormal changes in the outer retinal plexus. Moving further down, in the outer retina, we are able to see certain hyperreflective vessels in the end-fast OCTA, which potentially represent medium to large size choroidal vessels. These are not located in the outer retina, but these have been displaced upwards because of the retinal atrophy, and so we are able to see these vessels more superficial than their usual location.
And that is quite important to recognize that. In other words, yes, we know the anatomic landmark, but at times we have to recognize what stage of the disease that we are currently looking at, and also therefore what structure may be displaced so that we can now put them into perspective of where they are and why we're seeing them.
Yes, and actually, if you look at the choriocapillaries layer, you're able to see large vessels which are very unusual for this particular layer. Now these large vessels actually represent medium to large sized choroidal vasculature which have been displaced upwards due to the choriocapillaries atrophy. So essentially this lesion at the macula has extensive choriocapillaries atrophy along with changes in the choroidal vasculature, which is why there has been a displacement of these vessels upwards. And Dr. Wen, this is apparently a very important finding here that we are seeing here, because choriocapillaries atrophy, as you may know, may result in a significant photoreceptor damage.
And that is the point that we're able to use this new technology, which helped to allow us to know the status of the disease, because at this case illustrate, yes, we all try to control the inflammation, to manage our patient and to make sure that the inflammation doesn't persist. But at times, we need to recognize when perhaps the disease has reached a certain stage and perhaps this is an end stage. So we need to take that into consideration and discuss with the patient that perhaps at this point, the treatment and its potential complication may be the risk that overweigh the benefit for the patient, and therefore a good conversation and discussion with patient about the risk and benefit ratio for any type of treatment that we propose to the patient is quite important here, because the patient may decide that it is no longer worth the risk for him or her to undergo such treatment when we know that the potential for visual gain is no longer there. So I think again, we employ all technology possible to us to help us in the overall management of the patient, be it from the initial diagnosis to the monitoring to the choice and the various options for treatment at any time.
Yes, absolutely. Thank you very much.
Thank you for your attention, and we hope certainly that you have enjoyed our discussion on the use of OCT angiography in the management of uveitis, and we look forward to sharing with you additional experiences as we move forward with this new technology in our armamentarium for managing patients with ocular and inflammatory diseases. Thank you.